This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm T.G. Lafredo. Today on the program, it's part 2 of our look at the Emergency Medicine Residency Program at KRMC. We're talking with Dr. Derek Meeks.
I'm the program director for the residency here in Kingman, as well as an attending physician.
And Dr. Adam Dawson.
I am the medical director in the emergency department, and I function also as faculty for the Emergency Medicine Residency Program.
Before we jump into that conversation, I want to mention part 1, the previous episode. We visited with the chief residents, Dr. Max Doherty and Dr. Mitch Loehmann. They are in their final months here at KRMC, and they shared their reflections on what they've learned. If you missed that interview, you can find it in its entirety on YouTube. Just search KRMC ED Residents. You'll hear Drs. Doherty and Loehmann a few times in today's episode, but mostly we're turning the mics over to the attending physicians, Dr. Meeks and Dr. Dawson. Tell me a little bit about your interactions with the residents in terms of training.
Yeah, so on shift, it's a blast. We get to work together side by side as we collaboratively work up and care for patients. That is very much a side-by-side process. Separate from that, we get to work on projects within the hospital. Sometimes that means ways to improve processes. Sometimes that's reviewing data and trying to figure out how to just do better patient care in the community. Sometimes that's in teaching environments, and that could be locally, together side by side with residents. We've done classroom setting teaching. We've done community outreach teaching, different things such as that. And then separate from those, also there's a weekly didactic component where at times I'll have the opportunity to go be with them. They're there every single week. Sometimes I get to go participate in learning and discussion with them.
Dr. Meeks, your interactions with the residents.
Yeah, I have basically 2 environments in which I interact with them. And the first one, as Dr. Dawson said, is during shift work in the ER. We work side by side. We see every patient. We discuss every patient. We review all their testing. And during that time, in addition to the evaluation of the patients, we will often have times to do some extra teaching regarding those cases. And to be honest, they often teach me as much as I teach them. But those are always fun. And then we have didactics, as Dr. Dawson stated. Once a week for 5 hours, we meet in a conference room, and we have different styles of didactics. And so didactics or conferences, education, whatever term you want to use, we try not to do a lot of formal lecturing where we're just talking to the residents. We try to do a lot more interactive things, and we've increased that a lot this year. So we might ask them questions or have them do little assignments where they get together in small groups and then come back as a large group to discuss things. Sometimes we'll have teaching where there's actual hands-on practicing procedures. We often do teaching where there's practice for one of the major board exams. There's 2 major board exams at the end of the residency that they have to take, and one is a written board exam, and another one is an oral board exam where they are given a fictitious patient, and they go through the case. They're prompted a little bit. They are asked a lot of questions, and so we do that pretty much every week. We prepare them for that.
How many residents do you have at any given time?
We have 18 residents in our program.
And how long has KRMC been a teaching hospital?
KRMC has been a teaching hospital since 2000, the year 2000.
How does this benefit the community? And the follow-up is, how does it benefit the hospital?
There's a lot of misunderstandings in the community that the patients are going to be treated by students. First of all, residents have already graduated from medical school, so they're actual doctors. And they're in this residency program, which is a 3-year program. And each year they make tremendous strides in their knowledge and ability to care for patients. When you're in a teaching hospital like this, you are seeing both a doctor and a resident who are combining their brain power in solving or managing the case that the patients come in with. So you have multiple people looking at this, the cases and taking care of the patient. So you've heard the saying, 2 heads are better than 1. Sometimes it's 2 or 3 heads in helping with the case. In addition to that, when you are not at a teaching facility, oftentimes the education of those doctors is maybe a little bit older. It's been a while since they've gone to their residency, and they're not on the cutting edge of medicine any longer. Whereas in the residency programs, we're constantly learning the latest and greatest, the standard of care, the cutting edge medicine, and so they're getting really top-notch care, and they're getting the standard of care, the newest and best treatments. Medicine's constantly changing, and I've been practicing for 30 years, and I'm always amazed, even today when they were talking about some things in didactics, very, very different than when I was taught and trained. So if you're not at a teaching hospital, it's very easy to not know all the changes that are occurring. So the residents here, the people that live here in Kingman and the surrounding area, they're actually very, very lucky to have a hospital such as this that gives such great care. On top of that, our attendings are so dedicated and knowledgeable. They stay up on the latest and greatest things, the cutting edge medicine, because they need to teach that to the residents. So together, we each teach one another, and that results in exceptional care to the patients. And Dr. Dawson, you might have something to add.
Yeah, so oftentimes, thank you for that. Oftentimes I hear negativity regarding a teaching facility, and people then talk up these very prestigious places, and often the prestigious places they're quoting, in fact, every time that I've heard a prestigious place quoted, it's a teaching hospital. I don't know if I've ever heard of an example where a really fantastic level of care facility wasn't a teaching hospital. It does imply, in fact, more effort, more time, more brain power. So it really is an overwhelming positive.
And if I may add, there are studies that have shown that the care is better and more top-notch at teaching hospitals than at non-teaching hospitals.
A lot happens. Residents are here for 3 years, but there's so much to get in that time. I'll start with you, Dr. Dawson. What are some of the key lessons you want residents to come away from this program and have in hand?
The number one thing I want a resident to learn the second they're a new doctor and they're learning how to carry this weight on their shoulders is that this patient is in fact a patient who is quote unquote their patient. I want them to fully own that the well-being and the potential care/improvement of this patient is indeed on their shoulders. With that, the second piece that I really want them to own is the idea that this person needs to be cared for in a genuine way. The common way I like to say that is treat them like your family. What's fun and sometimes funny is sometimes our own family we don't agree with or we get in arguments with. And so sometimes patient care, the patient and the provider don't always see eye to eye on something. But the patient is the one in charge. And so that'll be a third point I'll mention is, hey, we're guiding the patient. We're not in charge of this person. We are there to help facilitate helping them, and we're guiding them in that process. And so cumulatively, I really want them to own that by the conclusion of their training phase when they go off on their own as attending physicians.
Dr. Meeks, core lessons for you?
You know, emergency medicine is actually one of the toughest jobs in the world, and the residency therefore has to be very tough. Each and every one of these residents that come through a program are so dedicated, they're working so hard. There's a lot of material to digest and learn. I've heard of the analogy, it's like putting your mouth over a fire hose and trying to drink everything that comes out. There's a tremendous amount to learn. Because the patients can come in with anything, any kind of condition, they really need to learn how to quickly recognize when there's an emergent condition that needs rapid treatment and stabilization, and how to address those things. One of the blessings of a residency here, or doing a residency here in Kingman, is because there's not enough physicians in the community. A lot of times people's health care is not addressed as quickly as it might in some big cities, and so they wait for a while before they come in, and they often come in with conditions that in the big cities you might not see very often. So our residents learn how to recognize and manage a lot of critical conditions that might not be seen frequently in other places. And I've actually had recruiters, physician recruiters, come to me and say that they come to our residency first before a lot of other programs because our residents are so ready to practice in any environment, whether that's a teaching hospital or a rural community.
We know that the doctors are learning in the ER, in the setting, the real world stuff, but also there are training scenarios that you come up with. Talk a little bit about those.
One of the easiest starting points for that conversation is probably to discuss the fact that they do both mock patients and mock procedures. Mock patients, for instance, Dr. Meeks referenced it earlier, will run through preparation for oral boards. And that's essentially where we have a pretend scenario. We walk through a clinical case, and as that individual resident physician, and then as a group, we get to discuss how to care for and manage that clinical scenario. And it's a great opportunity to discuss more than one idea or approach to get different types of feedback or input, because the practice of medicine can have variability as to recommended approach to things. But then separate from that, there are some hands-on procedures that occur, and before a doctor has their hands inside you, they're ideally practicing how to do that with their hands separately on a mock patient. And so we even have dummies, we do procedure checkoffs, and we'll go through and make sure that people get signed off on how to do procedures before we get into the real world with a real patient.
If I may add, there are so many different areas that we evaluate with the residents. Actually, monthly, every attending evaluates every resident and vice versa. And so those evaluations are sent to me and other leadership, and so they're constantly being evaluated, and when there's areas to improve upon, then we make those changes. We love the mock practice sessions. They can be done so many ways, either orally, as I mentioned, or with a mannequin or something, or some kind of task trainer that Dr. Dawson mentioned. My favorite ones are when we occasionally have the ones where we might have a mass casualty accident that people have prepared for us. We had one a few months ago, a separate one in the neonatal ICU, where we worked on a pretend baby, a couple of babies that were very unhealthy. And then there's another one coming up, I think this month, with OB/GYN patients or pregnant ladies who are in critical conditions, having emergent conditions. So those are probably my favorite, but all of those things help the residents get very well prepared for the real patients.
On those training days, or the crisis days, they also kind of throw some variables in that you...
Oh yes,
Yeah,
of course.
right.
That's the fun part.
Yeah, okay.
We don't want them to know what's coming.
We do a Mass-Casualty Training event every year that EMS kind of gets looped in on, and we can work with a couple of other groups in the community. And one of our attendings, Dr. Stevie Merrill, comes up with these big scenarios. And the one we did our intern year was a plane crash out at the airport, and they had been smuggling cocaine and exotic snakes. And so you had all the fake patients showing up. It could be trauma from the crash. It could be poisonous snake bites. It could be cocaine overdose. There were lots of things you had to work your way through to figure out what was going on.
That's great.
Mm-hmm.
Did they use real snakes?
I don't think so.
Okay.
Did they use real cocaine?
I'm still a little frustrated with Dr. Merrill. For years, I've been asking that we do a mass casualty scenario as a zombie apocalypse, but she refuses to do so.
You never know what's going to happen.
Do you fill out a comment card or anything like that?
They usually make me work on the day of this.
What's the standard of care for zombie treatment?
We don't want to put that on the radio.
Dr. Meeks, a moment ago, you talked about the residents collectively, how they have to be tough in this line of work.
Yeah.
And we talked about this a little bit earlier, but we know that by the nature of ER work, there will be some patients who don't survive. You're going to be parties to some really difficult stories. And I wonder how you prepare the next generation of docs to deal with that side of the job.
Oh, that's a great question. That education probably happens mostly on the job as you go through things, because every case is unique, and frequently you will encounter situations that are really difficult for anybody, even seasoned doctors like myself. Especially for me, it's the little kids and the babies that aren't doing well. That's really, really hard to see. And so generally we talk to the residents about those things, and if there's anything they want to talk about afterwards. We discuss that. We try to give them our insights and things that you only learn from probably bitter experience or difficult experiences on how to manage that. Aside from that, one of the great things about this ER is, as a group, whether we're talking about the residents, the physicians, the attendings, the nurses, the staff, we're really like a little family. And so there's so much support amongst all of us. Well-being and wellness is critical to all of us. I don't know if you're aware, but burnout is a tremendous concern in emergency medicine.
Sure.
So we are constantly addressing and doing things to help with wellness, whether it's teaching different strategies or just the support that they're given. We also have wellness days where we just go out and have fun together. We have one coming up, but one of my favorites was the paintball activity.
Did you get to settle some grudges there?
Yeah, I think they settled more on me than the other way around.
It's only right.
Yeah. So I try to stay away hidden as far away as possible. So I knew I was a big target. But seriously, burnout's a huge deal in emergency medicine. And so one of my favorite things, and one of the reasons I took the job from a person I knew that had it before, was this culture of wellness that we have in the ER and support. And I mentioned how great our attending doctors are, how smart and dedicated they are. They're also extremely supportive. Like it's not like you see on TV where they're abusing the residents in any way whatsoever.
Yeah, we talked about that too.
We did talk about that.
Yeah. So
Can we know what they said?
in those evaluations,
I named a couple of you.
in those evaluations from the residents, this place is special in that they're always very positive from the residents.
Yeah. You mentioned that you've been in this line of medicine for 30 years. Is this a change you've seen in the course of your career?
Tremendous change. That's such a great question, because when I was at their stage, it was completely acceptable to
They just beat you down.
Be rough on the residents. That the thinking back then was that would make you try harder and do better.
Right.
I think it led oftentimes to more burnout. And so it's very important to us that we have really good relationships with the residents, and we try everything we can to make their lives better, knowing that this is such a difficult residency and job.
Well, and also that focus on wellness, that focus on kind of finding ways to relieve that stress, and the supportive nature that also has changed over the course of your career?
Dramatically. I don't know exactly when it started, because I've only been in this position for a few years.
Yeah.
Maybe Dr. Dawson would know, but it actually has become an issue for everyone to be attentive to. We have an overseeing body for all residencies called the ACGME body. They help monitor that. But we have people and programs in place here to add an extra layer of wellness. We have a wellness committee, as well as just checking on them frequently and making sure everything's okay.
Yeah. Dr. Dawson, your reflections on that?
Yeah, so to further state and also clarify, the reality is residency programs are going to be difficult no matter what. The trick would be how to keep it from being more painful. It can still be a lot of information. It can still be a lot of work. It can still be 3 years of grueling efforts. But that doesn't mean we have to make it unnecessarily painful for reasons that don't make sense.
Yeah.
So some of this old school teaching approach that hopefully doesn't exist as much as we grow in the teaching of medicine, it doesn't have to be present today. It is important for us to treat each other kindly as colleagues. And I love what Dr. Meeks said a second ago. Oftentimes, it is like a family. And so we are going through some of the worst scenarios. I like to, when I teach the residents or when we talk about emotional burnout, or sometimes run through sad cases or chances to get this off my chest, right? Oh, it's so sad I had to experience this. It's important to talk about those things. But when we discuss those cases, we really emphasize the fact that, hey, people are coming here on their worst day. People don't go to the emergency room because it's a good day. They come because it's an absolutely awful day. Some of it really is their absolute worst day ever. And that can be painful, and that weighs on you.
Dr. Dawson, we touched on this the last time we talked. I want to revisit this topic for a moment. We know that there's a nationwide provider shortage, and we know that oftentimes the ER, the ED is the place where people need to go for primary care. So across the country, there's this idea like, oh, don't go to the ER because it's so slow. Is the ER slow?
From our side, it's hopping. The opposite of slow. Having said that, that doesn't mean it's that way for the patient. If a patient comes in and is showing signs of an active stroke, an active heart attack, a major trauma, it's fast. It's fast because the whole team's stopping what they're doing and putting effort on someone who needs immediate care. We love helping. I think everyone who goes into this field does desire to help. But in the world of help, sometimes it's harder for us to help every situation. So if something's been happening to a patient for not just a day, but maybe a week, a month, a year, we're not going to turn you away, but it doesn't mean that you're going to get prioritized to the front of the line. It's that triage system. And so the person with the critical condition is going to have things happen really fast. But we don't know if 100 people are going to show up today or if 200 people are going to show up today. And so if a larger number of people show up, things feel slower for a lot of the people. I usually like to tell patients, hey, if things are boring, if you're sitting here waiting, it's usually a good sign. If all of us come running into the room anxious, that's probably a worse situation for you. So just be patient with us. We do have a couple ambulances coming back right now. That's the coaching I usually like to do for patients so they understand, hey, if it takes an extra hour, it doesn't mean we're not trying to help. It just means that the system is bogged down for a moment.
I think it's hard for the patients. I know it's hard because there is a lot of waiting when you have maybe a lesser emergency or something that doesn't need immediate attention. And what the patients can't see through no fault of their own is that we're really working hard. Many times we're skipping meals. We never ever eat in the cafeteria. We always grab our food, rush back to the ER, and keep working. And I think sometimes patients might see us talking, maybe laughing or joking, and get the misunderstanding that we're not working hard. But that joking and laughter has to happen to stay mentally well and healthy and best able to take care of you. So we really do our best, and we would love nothing more than to have everybody in and out in an hour. That would be wonderful for us. But it's not the reality of emergency medicine right now because we are inundated. And as I mentioned before, there aren't enough physicians in this area. So a lot of people do come here for things that at other places where there might be plenty of doctors, they might just go to their family doctor or somewhere else.
A moment ago, Dr. Meeks, you talked about some of the benefits of working in these conditions where you have to stay sharp on whatever's happening in medicine, especially pertaining to emergency medicine. I wonder, reflecting on the big picture, why is teaching the next generation of docs, why is that important to you?
Oh, there's a lot of reasons. Some of it's probably selfish and personal because there's a lot of joy in working with the residents. They're young, they're excited. You see in them their excitement about things, and you're reminded about why you went into this field. You also see their tremendous growth, and it happens very quickly, and that's a lot of fun. And you feel a lot of pride in that, and a sense of purpose, success, like you've succeeded in helping the next generation take good care of patients. They're going to be taking care of me someday, so I'm kind of giving back that way. But because we're teaching, we're also learning to become better doctors. That's a really nice reward too. It's great to have people to discuss things with. It makes the care better, as we said before. It makes the job more enjoyable. You feel better at the end of the day when you've discussed the cases with a few people. You just keep learning and growing. And especially in emergency medicine, you have to keep learning and growing to provide the best care for your patients.
Dr. Dawson?
What was a big question?
And why is this important to you?
It's so much fun. So it's important.
That's a legitimate answer, too.
We need to train more doctors.
Yeah.
We need to have enough people to care for everybody. But it's fun helping people. And if I can help teach others how to help people, I'm helping more people in total. That's something a friend of mine mentioned that to me one time, and I've taken that to heart. Yeah. Separate from just the general idea of helping more and more and more people, it's a lot of fun. it's fun watching. So I hope I don't get too weird right here, but it's fun watching them think. I love watching their brains think and learning what they know earlier in their career and watching by the time they leave here to see how much they can do. Usually by their second year, they're smarter than me. And so at that point, it's more me helping to see how they facilitate the care, to see if I can help guide them into adjusting how they do things, to maybe to increase throughput, maybe to make it so the patient care is faster, or whatever the case may be. But it is so much fun watching them think and watching them grow.
Yeah. I'm interpolating here, right? But for a moment, it seemed like you were thinking, well, fun, is that a legitimate answer? But we've just been talking about what a serious risk for burnout you have in emergency medicine. If you're having fun, you're doing all right, right?
Absolutely.
Definitely.
I catch him watching me think all the time.
Is that weird?
Yeah, there's an HR report.
For the record, that's not true.
Oh, you've never caught him thinking?
Hold on.
Max doesn't think.
This is totally spiraling. So often when we are discussing cases and we're reviewing specific patients or care management for specific scenarios, there is a dialogue. And each person's at their own level of understanding in their process of caring for a person, okay? And so it's great. It's so much fun to ask a question and then to wait and see how they respond, and then to ask them follow-up questions to see if I can pick apart their brain to help them come to a completion of this thought. Yeah. And so the idea of watching, it's not a creepy from behind the corner. There's nothing weird about it, okay?
There was nothing weird for me until you suggested.
He mentioned HR. He said HR.
Well, doctors, in the moment that we have left, what is ahead? This is a program that has a 25-year history. What is ahead for the emergency physician residency program here at KRMC?
Oh, that's kind of a tough question, because as we go along, we are constantly making needed changes or improvements if we see that happening, if we see the need for improvements. So one thing I've been working on is trying to find ways to improve their learning, and mostly in the conferences. I actually come from an educational background. I've been a professor for about 20 years at a medical school in Vegas. So I really enjoy that. And in fact, we actually today, I asking for volunteers, we're going to form a subcommittee to discuss our didactics, our conferences, and how we can do better. As far as major changes go, there's been some discussion with our governing body over all the residencies. I mentioned ACGME. They're discussing implementing more changes to all emergency medicine residencies and maybe making them a little bit longer, like 4 years instead of 3 years, which most of them do right now. Those are kind of the big changes. We'd like to do whatever we can to improve their ability to take care of patients. And it's not just the bookwork type of things. There's a lot of nuances in medicine, tons of nuances in emergency medicine that you won't find in the books. And so the faculty actually help the residents along with that. Am I allowed to ask a question?
Yes.
Okay.
Yes,
all right.
it's encouraged.
Dr. Dawson, would you like to further expound upon that question, please?
Oh, look, you're going to put me out of a job.
You just repeated his question without even saying the question.
Exactly.
Okay, so from my side, the residents get to participate a lot in general improvement opportunities. In the practice of medicine, as things do progress and or change, or the town grows, or the hospital has to change how it's fitting within the space, there are ways to improve the process. And so oftentimes the residents get to participate in what we call quality improvement projects to ensure that we are growing and advancing appropriately to care for the community.
If 4-year residencies are coming, you guys picked the right time.
Oh, we for sure did.
Think about that a lot.
So if I can speak to that briefly, the idea of switching to a 4-year program, the concern nationwide, and the question is whether or not there needs to be more time to cover how much there is. Dr. Meeks mentioned the fact that it is like drinking from a fire hose. That's how much information. But as a kudos to our residents, they graduate from here with compliments from other facilities that they're ready to hit the ground running. We don't find from our program or our residents that they're lacking or that they're not ready for these environments. The feedback we get from other facilities and from hiring places is that, in fact, our residents are exceptional for that, which is what we want to hear. It's a huge compliment to them.
I've actually, at some of the national conferences, I've had people come up to me, see my name badge from Kingman, and say, I don't know what you're doing there at Kingman, but your residents seem to be head and shoulders above many residents we see. So that's very nice to hear.
It's as good a metric as you could ask for, right?
And they also are allowed to moonlight. About halfway through their residency, they're ready to moonlight. That's how quickly they've picked up on everything to be a good physician. So moonlighting, they can moonlight at various different hospitals, and we encourage that because that's a great learning experience too.
You've been hearing from Dr. Derek Meeks, Dr. Adam Dawson, and also two of our graduating residents, Dr. Max Doherty and Dr. Mitch Loehmann. Guys, thank you so much for your time today, and thanks for this insight into the program.
Thank you.
Thank you.
Thank you.
Absolutely.
And that is the program. That's another edition of Focus on Your Health. I'm T.G. Lafredo, and thank you for listening. We'll catch you next time.
Sure, I can talk for a little bit, but I only have so many words that I use in a day.
Yeah.
So just letting you know.
They're mostly prepositions and...
This is detracting from the amount of words I can use later.
Okay.
His wife says thank you.
We're off to a good start.